see some folks are still trickling in, but I have 1 o'clock Eastern, so we will kick off our call today. Welcome back, and thank you for being here to another week of Superior Health's COVID-19 Nursing Home Leadership Roundtable. I'm sure you see some of our familiar faces, and likewise, it's great to see you all back as well. My name is Kelsey Ostergren, and I am joined by Kim and Jerry, my co-leads, as well as Julie Campbell, who will be facilitating our Q&A today. And we are so excited to have Dr. Buffy back for her last of her 5-part series on nursing home infection prevention. So Dr. Buffy, thank you so much for being here. Before I turn it over to you, just a couple quick housekeeping announcements as we do every week. Just a quick reminder to those on the line, we do want to provide education, but as always, this is really your opportunity to ask questions of us and of your peers. So please use the chat box throughout the presentation. And I would encourage you at the end of the session as well to unmute and share as we have a little bit more informal discussion and kind of round robin. We will post the slides, the link to the slides in the chat box in just a minute. And as always, we will have a link to a session evaluation at the end and would appreciate if you could just take a couple minutes to provide your feedback. We do want to make sure these sessions are helpful. So if not, please provide us feedback or new topics, things that you're struggling with or want more info on, and we're happy to add those to an upcoming session to talk further about. So with that, Dr. Buffy, welcome back. Thanks so much for being here. The floor is yours.
Thanks, Kelsey. So happy to be here today, and thank you all for taking the time away from your very busy schedules. I know how valuable your time is and how busy you are, so thank you. I really do appreciate it. We all appreciate you being here. And as Kelsey mentioned, we are here to add value to you. So even you'll see I added a few extra slides that won't be on the final version that you'll get because we just had, there's some information that came through that I saw today that I wanted to provide to you. So, I'm like Kelsey, I'm Dr. Buffy Lloyd-Krejci. I'm with IPC Well, and today we're going to talk about COVID-19 prevention, containment, and mitigation strategies. This was our original topic, and I really feel that any one of you on the line could probably teach this webinar today. We've all been through COVID for the last 2.5 years, and so what I thought would be relevant is to kind of go over some areas that I see are maybe lagging in the nursing homes I go to. But I also wanted to talk about the new enhanced barrier precaution guidance from CDC, because there's a lot of talk and buildings that I just was in Michigan last week and went into 10 buildings, and people are trying different strategies to implement these recommendations. So I wanted to talk about that as well. And so our objectives today, so we're going to go and talk about the update of COVID-19 community transmission. And I want to show you where you can go to identify your own community transmission. I want to review the COVID-19 quarantine and isolation guidance. As I mentioned, I've been on site and I've been seeing a lot of different implementation practices as of lately. And a lot of that I've realized is because some of the emergency protocols that we had that we could implement have been removed. And so like setting up a barrier, that's a little bit harder. And so we're getting a little bit more creative, which is good and important, but I just want to talk about some of the fundamentals and remind you of what those are, and making sure that in your building, you're being able to address the need for those quarantine and isolation. I'm going to explore, along with the enhanced barrier precautions, also the new F880 revisions that CMS will be looking for as well. And we want to make sure that, of course, first and foremost, we're providing safe care to our residents and our healthcare workers, and then also that we're compliant with our state survey. And so with that, I'll go ahead and dive into our topic today. As always, I'd love to hear from you. If you could maybe put in the chat if you've been with, this is the fifth session I've been on, if you've attended all 5. How have they been for you? Has the information been helpful? Or if this is maybe your first time, even with me presenting, if you could let me know that too. I like to know who I'm presenting to, and just make sure that we're on track and we're adding value to the work that you're doing. So when we talk about COVID-19 community transmission rates, we know that there is a difference between the transmission rates and for the within the community, and then even just the community rates as far as the positivity rates. And so within long-term care, as many of you are well aware, we have different protocols that we follow with our transmission rates. And so CDC and CMS, CMS has a nice table that goes along with how we should be following different source control protocols. For example, if you have community transmission rates that are substantial to high, then we would be wearing like the face covering, eye protection. We would just be wanting to implement some source control measures that help keep our residents safe as well as our healthcare workers. In areas that are low to moderate, this is considered the more of the safer side of things. And, we are still requesting that visitors wear face masks and physically distance. The need for eye protection for our healthcare workers decreases at that time, and we don't necessarily need to implement that. But we'll go into a little bit more. This is just important to understand that the transmission rates is what we should be looking at when we're following certain source control protocols. Whoops. And so as you can see, this was just September 8th, so almost a week ago. Nearly the entire country is still in this red, the orange substantial to high transmission rate. You can see that over 85% are in high and almost 10% are substantial, and very few counties, this is by county, very few counties are actually in low or moderate. And so what does this mean for you? This means that we really need to be implementing source control. It also is indicative of how we are testing our residents and our staff, I should say. So how do we find the community transmission levels on the CDC? So you'll see here this link, and let me make sure I'm not sure I think that's hyperlinked. If not, we'll make sure we get it to you. But you'll go to the county view on the transmission rate for the CDC, and you'll actually put in your state and your county. Then it's going to pull up your actual, the geographic map. You want to hover your mouse actually over your county, and it's going to let you know what the transmission rate is. Now you need to be careful because directly above that, it'll actually show you a different, that's the percent positivity rate, which is different than the transmission level. And we want to be following the transmission level as far as what we're doing for source control. So there is a difference when it comes to how we're interacting with this map. So what does this mean again? So for testing, it also means we're going to be using certain source control, such as the face mask, the eye protection. The eye protection guidance is for moderate to from substantial to high spread. We want to make sure that we're wearing eye protection when providing resident care. Some facilities have a difficult time just implementing that for resident care, and so they'll implement it across the entire facility. And I know that's probably the biggest challenge I hear in facilities is the compliance of wearing that eye protection. But that still is part of the recommendations. Also, the transmission rate has to do with our testing. So if your county is in that substantial or high spread, you're going to want to be testing your healthcare workers twice weekly. Now, here's some guidance on that. So what does it mean if you're up to date? Okay, so if you're up to date, you've received all the doses of the vaccines, that are in the primary series as well as the boosters. And that's based on your age. Of course, people that are moderately to severely immunocompromised have different recommendations for the vaccines. And I just put that link there. It's important for you to check that. There are the bivalent vaccines now available, and I'm gonna show you a link that they are available for free and show you where you can go to get those. So I really like this page too. It's this page that's frequently asked questions about COVID-19 vaccines. I recommend that you bookmark this to your web browser. It's a really great page that helps you to get information quickly to your staff and even visitors. So I know you cover a lot on this call, a vaccine, so we won't go into this too much, but it's a good reminder of a great tool for your staff as well as your residents and your visitors. It really helps answer these questions that we could address really during this whole call. So as of today, this came about. So you'll this website here, if you look towards the middle of the page, it's COVID-19 Public Education Campaign. We can do this.hh.gov. This is a great resource that you can go to. The vaccines are available for free. The boosters, and while the government is purchasing them as of today, this was what came available. And then here is a website where you can find a COVID-19 vaccine near you as well as the new boosters. So I am recovering from COVID right now. And I just will say that I am a huge advocate of the vaccines and boosters. I can't even imagine what my illness would have been like had I not been boosted. So please continue to provide this education, even if you are in areas that may be more resistant to it. I understand. I've been in plenty of those areas, but it really is critical that we continue to educate on the importance of the vaccines and boosters. They really are protecting our population and keeping people out of the hospital and keeping people from dying from COVID. And this is really important, of course. So I want to talk a little bit about COVID-19 containment strategies, including the quarantine and isolation protocols. So as a reminder, according to the CDC, a COVID-19 outbreak indicates the potential extensive transmission within a setting or organization. Now, we know that, and if you've had an outbreak in your building, you know that it can really spread like wildfire. And so we have to be aggressive. Excuse me, we have to be aggressive in our strategies to ensuring that we are keeping our community safe and protected. I want to remind you that even with one healthcare worker or one resident that is positive for COVID, this is considered an outbreak per CMS. This is the same for influenza as well. This is nothing really new to our industry. And so an outbreak, the definition of an outbreak is if you have more than what's normal, and any case is considered an outbreak. So how do we mitigate an outbreak? Well, the first step is to contact your county health department, of course, to partner with them. You may also consider contacting your state health department, the HAI division. We want to make sure that we're taking their guidance and that we're following their lead. They may have information new to your county that you may not be aware of, and so we want to rapidly involve them in our mitigation strategy. The second step is to commence or expand your COVID-19 testing. This will include contact tracing or broad-based testing depending on the circumstances. So this was really great when CDC came out with the opportunity to conduct contact tracing versus simply broad-based testing, because now we can really identify, let's say that the outbreak started in the kitchen and that the kitchen attendant didn't go near any residents, and you're able to then further identify maybe where that case came from. If you can identify that it didn't actually, there was no type of exposure to a resident, then we don't need to have residents quarantined. And we can just isolate or quarantine residents or staff that have been exposed. So and based on certain definitions. So this is good, and I highly recommend that you utilize the contact tracing. Obviously, if it is facility-wide, it may be easier to do broad-based testing versus just the contact tracing. So those are options for you. The third step is to make sure to place any residents that may have been exposed on a quarantine. This is if they're not updated with their vaccines to mitigate the spread. So to reduce that ongoing spread of COVID-19. And then, of course, we want to monitor residents with suspected or confirmed COVID. This includes ongoing assessments of their vital signs, their oxygen saturations, and their respiratory exam. So some testing considerations. This is some of the questions that I get on a frequent basis is who's up to date, who's not up to date. I just had 1 shot, I had 2 shots, I didn't have any shots. So routine testing of staff, this is based on the community transmission like we just talked about. It is for staff that are not up to date. And remember what I said about not up to date, that means that they have not received their either primary boosters or that are updated. So they want to have the primary series as well as at least 1 booster at this point. You should use that community transmission to trigger the level of staff testing frequency. So typically, if it's substantial to high, you would do twice-a-week testing. And then if it's, I think it's the moderate, it's once-a-week testing. And if it's low, then no testing is recommended. The CDC recommends that if we are doing testing for the point of care testing, this is really important. And I see a lot of these infection control practices, they're not occurring right now. And we really need to evaluate our how we're collecting the specimens and if we're implementing proper infection prevention when we're actually conducting the specimens. If you think about it, if you're doing facility-wide testing or you're testing your residents and you're not in a clean environment, or maybe hand hygiene isn't good, or you're not wearing the proper PPE, then that could be putting the person at risk who's actually collecting the specimens. So excuse me, we want to make sure that we're disinfecting the surfaces, that there's that 6 feet of separation, from people, from the handling and collection of the specimen. We want to make sure that disinfecting happens before testing begins, between each specimen collection, at least hourly during testing, obviously when visibly soiled, and obviously, of course, at these other times when there's a spill or a splash, and at the end of every testing. The best way to implement this is to have, a container of maybe a sandy wipe, bleach wipe, having a handy wipe available that you can, and gloves available, making sure that you're using gloves, changing gloves after every person. You can wipe down the surface. You want to make sure that you have a gown on and an N95 respirator as well if you're collecting those specimens. If your staff have been trained to do self-testing, I encourage you to make sure you have it documented that they have been properly tested and that you can show compliance for that, competency training for that. This is something that I know the surveyors will look for, and they want to make sure that you have documentation on that training. So what do we do when we're managing residents with suspected or confirmed SARS-CoV-2? This is taken straight from the CDC. This is not Dr. Buffy's opinion. I didn't make this up. This is the CDC's guidance. And I say that because almost every building I go into has a different process for implementing this. And I highly encourage you to follow the CDC guidance word for word if you possibly can. It's going to offer the highest level of protection as well as help keep you in compliance with the surveyors. So if you have a resident and a healthcare personnel is providing care to that resident, they're suspected or confirmed. Now, suspected can even mean if they're a new admit, and they're on that 10-day quarantine. You want to make sure that anybody providing care is wearing the gown, the gloves, the eye protection, and the N95 respirator. Ideally, we want those that are suspected with SARS-CoV-2 to be in a single private room with a private bathroom. This is especially true while test results are pending. I know that's not possible for every building, but if you can at all possible, try to do this, because of course that's going to keep them protected and not put other residents at risk. Also, it is recommended to keep the door closed for these residents if they are suspected or confirmed. And the reason we do that is because we know that this virus can be transmitted through the air, through aerosol, through the air particles can travel through the air. And so we're trying to keep the door closed. However, if it's not possible to keep the door closed, which in many instances it's not safe for the resident, then first we need to make sure that you have this care plan, that if CMS or surveyor asked you about this, that you can demonstrate to them that you're aware that this is the best practice. Also, I encourage you, this is CDC verbiage, remember, to work with your engineers to implement strategies that minimize airflow into the hallway, so they can identify how the air is moving. Is it moving into the hall? Is there a way that they can change the airflow to where it's moving out of the hall or out of the corridor? And so work with your facility, your maintenance supervisor, your engineers, and then identify if that's possible, about if you have to keep the doors open. Many facilities I go into now just have it a practice not to close the door. And we don't want that to be our practice. We want to try to keep the door closed, but if it's not possible, then we can follow these other protocols. Okay, so again, as we're continuing to manage the residents with suspected or confirmed, we want to have a single room if possible. If the resident does have a roommate, then if they do have a roommate, then we want to manage them under the same section, basically. So we would want to have the gowns, the gloves, the N95 respirator. Try to keep that curtain closed if you can. But again, if you can put them in a private room, that is best practice. We only want to place residents in a COVID care unit if they actually have confirmed SARS-CoV-2 infection. It's very disruptive, as you're aware, to move residents if they don't have COVID. Also, I know many places, and I'd be curious what you're doing if you're sheltering your residents in place. So if you could maybe put in the chat, yeah, we're excuse me, we're sheltering in place. We don't move our residents anymore, or yes, we still have a COVID unit. We want to make sure that we're increasing residents suspected or confirmed of their infection. This is that if they have, we want to again increase the resident monitoring for these residents that have suspected or confirmed. Here's a couple of signs that you can use with the links available. One is from the Washington State Healthcare Association. One is from Leading Age. And I like these signs because, well, a couple of reasons. First, they actually have pictures of what's required. They both talk about the door being closed. It's helpful to have this type of sign. I have got some pushback about calling it aerosol contact precautions. So if that is something you're concerned about, just stick with the special droplet contact precautions, not a problem. What we don't want to see is we don't want to see a sign that just says standard precautions. We also don't want to see a sign that says enhanced barrier precautions. I've seen that recently. We want to be very clear that this is special droplet contact precautions. And probably one of the most important things is that we have the discussion of the N95 respirator on there, as well as keeping the door closed. That's what distinguishes this type of precaution from any other droplet or contact precaution. And if I'm a visitor to your building, if I come into your building and there's residents that are on this precaution, how will I know unless I have clear signage that indicates this? So consider utilizing one of these signs. I just want to mention too, it is for the new admissions. We want to make sure that it's no longer recommended to have them on a 14-day quarantine. The CDC changed that in April of this year to a 10-day quarantine with, it's seven days with 2 negative tests or 10 days. So we want to reduce the amount of isolation as much as possible. And so if you're still doing a 14-day quarantine, please consider changing to that lesser amount of time. Not only is that helpful for your healthcare workers, but it's also, of course, helpful for your residents. Okay, so let's move into enhanced barrier precautions. I wanted to briefly talk about this today because every building I go into, I have lots of questions on what's being required, and I'm seeing all sorts of interesting ways to implement this. So I want to talk through that a little bit, and of course, answer your questions that you may have as well. So I will tell you, I borrowed these slides with the permission of Dr. Namali Stone from the CDC. We have been doing quite a bit of collaboration on this. And so I thought, why reinvent the wheel? She did a great job with these slides. So these are all her slides. So the definitions of common terms of abbreviation. So the multi-drug resistant organisms can include bacteria or fungi resistant to multiple antimicrobials. Colonization are germs that are found in the body or on the body, but they are not causing an infection. And this is important because the reason we're actually implementing the multi-drug resistant organisms is because of colonization. We can't see the germs, we maybe don't even test for it, but there is a high risk of multi-drug resistant organisms that are colonized within our long-term care residents. There is this great research that was conducted that shows that of this research study of 18 facilities that were in this study. It showed that methicillin resistant S. aureus was a frequent pathogen in up to 60% of the residents, and that the beta-lactamase producing gram-negatives were approximately in 30% of the residents. Then the median of the carbapenem resistant prevalence was 10% in nursing homes that had ventilators. So you can see here that the 58% of residents had carried the multi-drug resistant organism, and then facilities with ventilators that went up to 76%. So we can see here the risk that is associated with the multi-drug resistant organisms. You may have heard of Candida auris. It is definitely a pathogen that is making its way through long-term care. It is an emerging fungal pathogen. It is shown to be drug resistant, and it is colonized in individuals that have a risk of invasive infection. About up to 10% residents will develop C. auris in the bloodstream with the infection within a year once they're colonized with it. And it spreads really easily in our healthcare settings. It's very similar to the resistant bacterias. And so it's one of those resistant pathogens that the CDC is really keeping their eye on. And it's something we're really working hard to prevent in our long-term care facilities. So I liked this prevalence study. A prevalence study is where you just take one day and you test everybody in your facility, and then that's your rate, that's your percentage, that's the prevalence of infections that one day. It's a one point in time. And so in March of 2017, C. auris was actually tested within a long-term care facility that had 69 residents, and only 1.5% were found to have C. auris. Just to show you the prevalence of this pathogen and how it's spreading, in only 1 year later, another, less than a year, actually, about 10 months later, another prevalence study was conducted on a ventilator floor, and 43% of those residents tested positive for C. auris. So you can see just in that 10 months of how dramatic, how it had changed over that short time period. So this is why I'm giving you the why of why we're implementing the enhanced barrier precautions, because it's important to understand the research and the motivation of why these measures are being implemented. I really like this diagram. It shows the challenges with detecting multi-drug resistant organisms. And I really like, it shows that the number of infections are kind of the tip of the iceberg. It's kind of what we can see, but then underneath it is this mass reservoir of transmission that we don't see, we don't detect because we're not testing. And so this kind of gives us an idea of like, it's underneath, it's the iceberg that we don't see, that we're really trying to help prevent the transmission of those multi-drug resistant organisms. So they're the asymptomatic carriage, and research has shown that it's significant and that we really need to do what we can to prevent it. And so here's an example of what that looks like, documented versus actual colonization. In the same facility that had 14 nursing homes, you see there were 17% of the multi-drug resistant organisms, 17% were documented, whereas 58% were the actual number. So you can see just this huge amount of actual multi-drug resistant organisms that weren't detected. And then look at the ventilator units. I mean, we're talking 20% were documented, but 76% were actual multi-drug resistant organisms. Again, colonization. And I think that you'll be able to identify with this. I mean, if you really think about your own practices in your facility, how many times have you got a resident that you're going through their chart, you're going through their records, and you're like, oh my gosh, they had CRE, they were colonized with CRE, or they had MRSA and we didn't know about it. The communication between our other healthcare providers is lagging, and that's part of the reason why we don't detect the multi-drug resistant organisms as needed. And so given this research, given the amount of undetected MDROs, we really need a new way to address that. And that's where the enhanced barrier precautions has come in. It is to be able to prevent the ongoing spread, reduce the spread without isolating residents for a long period of time. Traditionally in our hospitals, if a resident or if a patient has a colonization of a multi-drug resistant organism, then they're put on contact precautions for the course of their stay. And that's not realistic. That's not what we do in long-term care. And so the best way that we can approach this is by allowing them to be able to come and leave their room as they need to, but then wearing the extra PPE, specifically the gown, when we're providing the level of care. So these changes came about July 12th. I'm very familiar. When that week came, I got so many emails flooding my inbox about what to do and how do we do it, and the challenges, like the PPE burn rate and the challenges that this was going to pose, and and the concern about the residents feeling like, they're doing something wrong. So there's all of these barriers to implementing this practices, which I completely understand. And that's truly what makes long-term care unique, is that we have a population, a vulnerable population that is at higher risk for these types of infections, and yet this is their home. So how do we handle that? How do we manage that? So we'll talk through that a little bit. So the indications for utilizing the enhanced barrier precautions has changed, and what is indicated now is that they're indicated for residents that have an infection or colonized, when contact precaution otherwise would not be applied to wounds and or indwelling medical devices. The wounds seems to be, people understand that more, but the indwelling medical devices is what's really creating a challenge. It is not limited to outbreaks or specific multi-drug resistant organisms. So even if you didn't have any residents in your building with an MDRO, you would still apply this practice, because remember, remember the reservoir underneath the iceberg, right? We can't see all of those that may be there. And so that's what we're trying to prevent. So the recommendation is to wear the gown and gloves for the high contact resident care areas. This is for dressing, bathing, showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care, use of a device, and wound care. So, and remember that this is for any wounds and or indwelling medical devices. So this is definitely a lot to implement. And so we want to use, here's a great sign that we want to use the enhanced barrier precautions for use of the gown and gloves during high resident contact area. No private room is required. Residents can still participate in their group activities, and it is intended for a prolonged period of time, the entire length of their stay or until the risk factors are no longer present. Let's say they had an IV, and if it was discontinued or a catheter is discontinued, then they would no longer require the enhanced barrier precautions. The successful implementation of this program, what I like to say is the enhanced barrier precaution is one piece to this. I love this slide. I love it so much because infection prevention is not, we do one thing and now we reduce infections. It's never like that. We have all of these different processes that we implement, and then together we look towards reducing infections. So it has to be part of a program that involves significant hand hygiene, environmental cleaning and disinfection, the enhanced barrier precaution, auditing to ensure that these other processes are making sense and they're implemented, and then communication. Communication is one of those greatest barriers that I see again with our healthcare partners. And so together, all of these steps can help reduce the risk of the multi-drug resistant organisms transferring within or spreading within our community. So here's the sign again. I highly recommend printing this, laminating it, teaching the staff about it. I just did a in-service for some of the nurse aides last week, and really asking them the pertinent questions like, who is this for? When is it indicated? Are they sick? Do they have an infection? Helping the staff understand why we're doing this, and teaching them, even giving them the understanding of these organisms that are transmitted in these facilities. And we're doing this to keep them safe. We're doing this to keep the residents safe by educate the housekeepers, educate your nurse aides, educate the staff that are in those rooms every single day. So then they can even help educate our residents that are like, why are you always wearing a gown? It doesn't make sense. I'm not sick. And they can say, you're absolutely right. You are not sick, and we are here to protect you. That type of messaging is really important. So this is I'm just going to post these. This is exactly what we just talked about. this came word for word from the F880 infection control revisions. This is what the CMS surveyors are looking for. I don't know if this is going to be, if they're going to start looking at this in their revisions in October, but just be aware that this is what they have implemented into their survey process. Please, at the very least, include these definitions in your policies, your plans and policies, so that you can show that you are working towards this plan of implementing enhanced barrier precautions. Here are some resources for you. Feel free to add these to your policies. You can just take them straight and add these exactly where the guidance comes from. I just want to briefly, I have a couple more minutes, want to talk about some infection prevention strategies. I would be remiss if I didn't go into this just for the final couple of minutes, but I just want you to know that my dedication as a fellow infection preventionist is to not only reduce the risk of these multi-drug resistant organisms, but there are 1 to 3 million infections that are occurring in long-term care every single year that result in 380,000 deaths. This was before COVID. And we, as infection preventionists, have a responsibility to work towards reducing these infections. And up to 70% have been documented that can be preventable. So if you think about over 1,000 people are dying from infections every day, and if maybe 700 of those could be preventable, well, that gets me up in the morning. That gets me excited to be able to do something about reducing these infections. And so how do we do that? So one solution is that we shift from a reactive to a proactive infection prevention and control program. So we know that the 2019 IP requirement, we have a part-time infection preventionist on site. If you're on this call and you're in leadership, I ask of you to really make sure that your infection preventionist has this dedicated time that they need, that they have the training. And now there is the CIC certification available for our long-term care, our IPs. The application goes through October 3rd. I encourage you to sign up, have your IPs to study for this, to train for it. It is an investment that you will not regret. It will teach your IPs. And if you're an IP, it will teach you more than you ever could have imagined just by studying for this exam. And it will really, really help you become the expert in your facility and really start taking those steps to reducing those infections. I also want to offer you a free, so my company, IPC Well, we created a learning library that is available to IPs. We're still working on it. We have 10 modules that are available. It is free to you. Your IPs, the number one thing we hear all the time is that we don't have the time to find and identify what we need. And so here's a learning library. It has resources. It has Excel spreadsheets for data. It has tools that you can use. And we just encourage you to feel free to reach out to us, and we're happy to get you signed up for that. And then finally, if you haven't done so, I do encourage you to order a copy of my book, Broken. And this book is a story that honors you as healthcare workers, and it describes our challenges that we have gone through in our industry and the help that we need, and really advocate for changes moving forward. So I hope that you'll get a copy and share it, and then share in the solutions. That's really what is important to me, is the solutions for change. There's the link for that. It's on Amazon. And I just thank you so much for the opportunity to be able to present to you over these last 5 months. And here is my contact information, my website, if you would like further information or support from us. But it won't be the last time, I'm sure, that you hear from me. So we seem to hang in there quite a bit. So anyway, with that, I'll turn it over back to to you guys, and we'll go from there with our questions.
Awesome. Thank you so much, Dr. Buffy. Your sessions are always so informative and just jam-packed with very actionable, tangible resources that I think everybody can use in their day-to-day practice. So thank you once again. I want to start just by sort of acknowledging there's been some chatter in the chat box about up-to-date and what's required. And can you just talk a little bit about how the bivalent vaccine fits into that?
Yeah, great question. So I'm just kind of reviewing the chat now. So the bivalent vaccine would be considered up to date. So if you have your primary series and then you get the new vaccine, then you would be considered up to date. So that would be you wouldn't need to get 2 boosters or anything like that.
Okay. And then can you touch on as well the over 50 population? Because they're asking, since that group is recommended to have 2 boosters, if they only have 1, does that mean then they're not up to date?
That's correct, as of right now. So the currently what was available before the bivalent booster was the recommendation was over 50 that there was recommended to get 2 boosters. But again, so let's just say you have 1 booster and you're over 50, I would suggest getting the bivalent, and then you'll be considered updated. And then, but there are some other criteria if you're immunocompromised. So I would encourage you to look at the CDC recommendations if you're immunocompromised for what it means for you to be up to date. It is different. And so I believe it maybe even include two doses as well.
Okay. Awesome. And I see Elena just posted a resource in the chat as well. So Elena, thank you for doing that. Another comment, and this sort of goes back to the conversation, Dr. Buffy, that you were sharing about resident colonization of MDROs, and you sort of presented 2 groups of data sort of in this longitudinal study, and the later group was from a ventilator unit. And so this individual is asking if there was any data from non-vent units, just given that susceptibility and acuity of the residents in those units typically isn't comparable perhaps to just the general population.
Yeah, let me go back. They are, I don't know if this is what they're talking about, the ventilator, the prevalence. But then here, this is talking about the carriage of multi-drug resistant organisms that are just a regular skilled nursing facility. So it does show both here. It shows these 14 skilled nursing facilities. 58% was the median MDRO carriage, and then 76% was for ventilator units. So, I mean, it does show that it was still over 50%. It does also show that the ventilators, the units are higher risk, which makes sense. I mean, it definitely is a high risk. So, so maybe that this research study would be your best bet to dive a little bit deeper into that.
Okay, thank you. And then the 2 slides before this, those were both from the same ventilator unit, correct?
So this one, I'm actually not, I think so. I believe so. I haven't dove deep into that, but I believe it was the exact, it was coming from the Chicago Department of Health. And so looks like that was the same ventilator floor.
Okay, great. So then that data would then be comparable because we're comparing the same patient population sort of pre and post.
This is, and it's only like, I mean, if you see March of 2017 and then January of 2018, it's the same, it's not that far apart, right? And so you can see here, pretty big increase.
Okay, great. Well, thanks for just revisiting that to clarify.
Yeah, no worries.
And then there was another question about the 14-day and 10-day changes. So Angie asked, is the unit in outbreak for 14 days from the last date of exposure, or has that changed to 10 days as well?
No. So it's 14 days from exposure, but the 10 days is how long a resident is on a quarantine. So if the resident is exposed and they're not up to date, I have to make sure I say that right, then they would go on a 10-day quarantine. And as well as if they had COVID, they would go on a 10-day isolation. So that's what's different about that. The quarantine time period used to be 14 days, but now it's actually 7 days with 2 negative tests, or 10 days. So absolutely at 10 days, they would come off of that quarantine.
Thank you. Hopefully that helps, Angie. If not, you can feel free to unmute or add some more comments in the chat there. All right, what other questions or comments or thoughts do the group have today?
I do see here Jody mentioned that on a COCA CDC call yesterday, it was shared that anybody that's 12 or older with the Pfizer and 18 and older with Moderna is considered to be up to date with the bivalent booster. So even if they've had the old boosters, so that makes sense. 2 months after the series completion or 2 months after their last booster. So thank you, Jody, for providing that. That information. So basically everybody is going to need to get the bivalent booster to be considered up to date. And it looks like Stacy mentioned CMS states they will not be surveying to the change definition of up to date yet. That's good to know too. So that'll give people some time to get caught up with that. One of the things I want to talk about that I saw on site with the enhanced barrier precautions is, and I knew this would be a potential challenge, but as the recommendation is, the residents don't have to be in a private room. They can have a roommate, but, and so some facilities I've been in are looking to cohort residents that both require enhanced barrier precautions to make it easier on having easily accessible PPE outside of the room. Just keep in mind, that's totally fine. You can do that. Just keep in mind, we must educate the staff and then continue to audit to make sure they're implementing this practice, that they are changing their gown in between each resident. So we don't want, I mean, especially if your staff have worked on a COVID unit for a long time and they didn't change their gown, it's a shifting in their thinking that they need to make sure to change their gown after each resident. The residents are not sick, they don't have an infection, and so we're protecting them from us and the environment. So it's just really important to make sure that we remind the staff about that. I saw a gown hanging up in one of the rooms that I went into, and I said, no, we don't want to reuse the gowns. We don't want to share the gowns. That kind of defeats our whole purpose. I also, in talking to the long-term care team with CDC, they are working on a document to provide to nursing homes on just some tips and ways to implement this. If you have a good system going, or if you would like to contribute to that, if you could let me know, I can have you talk with the CDC long-term care team. Any input from our industry is helpful. And so if you would be willing to talk to them about what you're doing or what's challenging, then please let me know and I can put you in touch with them. it's always helpful for them to hear that from the field and make those decisions. So I just want to put that out there as well.
And Dr. Buffy, there is one more comment in the chat here from Angie. She said, I'm not sure I understand why a resident who is not up to date and was potentially exposed can come out of quarantine, but the outbreak on the unit continues. I understand the incubation period is 2 to 14 days, but then why the lessening to 10 days?
Yeah, so that's a really great question. So the individual that potentially was exposed, the research has demonstrated that, I mean, this is true for somebody that's infected too, that after 5 days, they would no longer, they're not as infectious, or, even we have that return to work guidance after 5 days, but after 10 days, they're really not suspected to be shedding if they have the infection, right? So that's for isolation. And so in an effort to reduce the time of isolation or quarantine with the testing, the research has demonstrated that you're more likely to test positive within 4 days actually than any from exposure than prior to that, to then later than that. And so I think 10 days is probably a good, gauging period from the time you're exposed. Now, the whole outbreak, because there could be other exposures within that time period, we don't exactly know when maybe somebody else was exposed. And so having a little bit longer time period for the entire building is helpful, just to continue to make sure we didn't miss anybody that may have been exposed, and then we didn't catch them. So it's more for testing purposes for that 14 days. And then Stacy also mentioned it too, as well as just the psychological well-being, but also it really is, I mean, this research came out quite early, even showing that the median time from exposure is 4 days before symptoms start. But then there are those rare exceptions that do go all the way up to 14 days, although like I said, it's not as common. So in public health, it's very difficult. You want to make those decisions that protect the entire population, and coming to a middle ground is sometimes what you have to meet in order to best protect everybody, and avoid some unintended consequences too, which, knowing if you're in your room 14 days versus 7 to 10, that is a long time to be isolated in your room. But I also want you to keep in mind, that's for residents that are not up to date. So I don't know about your facilities, but in many buildings that I'm in now, a large percentage of the residents are up to date. So that should really help with not having a whole lot of residents on quarantine, even if they've been potentially exposed. Great question.
Yeah, this has been a great conversation. So thank you so much to everybody who's put questions and comments in the chat. The resources that were shared both in chat and Dr. Buffy by you as well. I want to be cognizant of time. I know we're somehow already at the end of our hour together. Time just always seems to fly by. Before we close our session today, I see Jerry just put the link in chat for the evaluation. If you could just click that and provide your thoughts in a couple of minutes, that would be great. And then next week, just a heads up, our conversation on this call, we're going to be talking a little bit more about data. So we'll be joined by Gray, who's one of our analysts at Superior Health, just to talk a little bit more about the kind of data that we look at Superior Health and how we can be helpful to you as you're reviewing and looking through some of these infection control measures and immunization measures, and just sort of be an additional resource and set of eyes for you. So with that, Dr. Buffy, thank you so much. It's incredible to believe we've already gone 5 months and 5 sessions, but it's been such a pleasure having you. Thank you for your wealth of knowledge and for sharing that with us on these calls. And I'm sure we'll see you again soon.
Thank you so much for having me, and thank you for all that attended. I really appreciate you and all that you're doing.
Absolutely. So with that, have a great afternoon, and we will see you all next week.